Good evening. This is Dr. Laiq Raja from El Paso, Texas, Interventional Cardiology, and it's an honor for me to participate in NCVH Digital Education Series program. I'm very thankful to Dr. Craig Walker. My topic today is orbital atherectomy for calcified peripheral arterial disease. These are my disclosures. So let's talk a little bit about calcification, why calcium is so important. If you look at the cases and all the procedures we do, calcium can lead to many different complicated issues, including severe dissections, embolization, unable to dilate, and poor stent expansion, procedure failure. So basically, one of the challenges we see more among different pathologies is the calcium. Now here again, let's talk about different effects caused by heavy calcific vessels. Again, 74% for limiting dissections, which are much larger for calcified versus non-calcified plaques, unable to dilate the balloon and effectively leave the drugs behind during the procedure. There's a significant vessel recoil, we see it, and again leading to decreased stent expansion, which obviously can cause stent fractures and decrease patency in the long run. There are certain risk factors which are related to calcium. As we get older, there is more incidence of calcium, but three main things are smokers, diabetes, and chronic kidney disease. And they are sort of additive to one another. Somebody who has all these four risk factors, we usually see a severe, heavily calcified vessels. How to define and what are the different definitions of mild to severe calcification? And geographically, what most of us that we use this is from Peripheral Academic Research Consortium. It goes by the length and the circumferential, how circumferential calcification is start from focal, goes all the way down to the severe calcific vessels. This is one of the studies I think everybody knows about it. Dr. Finelli did, where it was a drug-coated balloon angioplasty, and we clearly saw that as the calcium increased, there's a significant decrease in primary patency and increased lumen loss, late lumen loss, again suggesting that calcification might be a hindrance into the absorption of the drug into the vessel wall. This was again shown by Dr. Teppe's study, where again it showed that if you have a heavily calcific vessels, then it leads to a significant increased lumen loss. So we know that calcium in peripheral interventional procedure is one of those things which complicates the procedure, and also the long-term outcomes could be not ideal. So in addition to looking and identifying calcium by fluoroscopy, which we know by far is not the best way of looking, so intravascular ultrasound is much easier to use, and it really tells you not only the calcium, but also where is the calcium. Is it in the intima or is it in the adventitia? Why is it important? Yes, it's very important to pick the tools, the devices we're going to use if it's intimal versus adventitial. OCT is another very important tool which helps us to localize and identify how much the calcium we have, and also to some degree extravascular ultrasound. Now let me give you some examples. Like this patient has severely calcific vessels, as you can see, without any dye. You can see where the AT and PT are, but do we really know where the calcium is? Yes, we did an ultrasound, and you can see is a 360-degree intimal calcification. Now, on the other hand, same sort of angiographic looking artery, but when you look at the ultrasound, this is adventitial, and actually it's a very soft plaque, right? So you can't really rely on angiographic or fluoroscopy to tell you where exactly is the calcium. Now, what are the different treatment modalities available for treating patients with severely calcific vessels? We know that balloon angioplasty or stenting directly probably may not be the right choice, leading to, as I explained before, multiple complications. There are certain atherectomies which has been used by debulking the calcified area to decrease the compliance, increases or improve the compliance and have a better results. Directional, orbital, rotational, laser atherectomy, and then lithotripsy, the shock wave, is a new kid in the block which has very good outcomes. And again, if nothing works, a surgical endarterectomy can be used to get rid of all the calcified areas. So today I'm going to talk about one of those atherectomy devices which has been used for calcified plaques, orbital atherectomy. So there are certain characteristics of orbital atherectomy. On the right side, you see this animation. You see that the crown is built eccentrically to the wire. The purpose of this is that as the RPM or the speed increases, it goes and cuts more and more. So not only that, with increased RPM, you can get a better lumen. It also can cause a deeper impact on the deeper calcifications to create cracks, which obviously can lead to a better compliance. Now, if you look at the left side, differential sanding, this is another characteristics of this orbital atherectomy, that when we are using the orbital atherectomy in a vessel, there are certain areas which has a relatively healthy vessel and other ones have heavily calcific, so it kind of bounces off the healthy calcium, healthy vessel, and leads to more cutting towards heavily calcific sites, leading to eventually a very smooth lumen. There are three different kinds of atherectomy crowns available. One is called classic crown, micro crown, and solid crown. So if you look at the classic crown, it is a pretty low profile and very flexible. So it's usually used in the osteal areas which has a lot of tortuosity. Now, micro crown is very popular for tibial vessels, and since it's compatible with 4 French sheath, so it can be used retrogradely from the tibial vessels. Solid crown has a much more mass in it, so it's very effective in debulking of bigger vessels. So for a larger vessel, this device is used. What is the data behind it? So there are multiple different clinical studies done for orbital atherectomy, as you can see in the slides. I'll just go through a couple of them. Now, this is a compliance 360 trial, which was PTA with orbital atherectomy versus PTA alone for above the knee vessels. And you can see on the left side that maximum balloon expansion or pressure was much less when you are using orbital atherectomy compared to PTA alone, and which leads to much less provisional stenting by increasing the compliance. Primary patency at 12 months were the same in both arms. This is a calcium 360, which was below the knee study. Again, PTA with orbital atherectomy versus PTA alone. Again, we can see statistically significant decrease. Less balloon pressures are needed to inflate or completely dilate the balloon. And then on 12-month results for freedom from revascularization and major events, you can see in the slide, which were favorable to balloon orbital atherectomy with PTA. I would like to show a couple of different studies to look into how it's utilized in clinical practice. My first presentation of the case is an 83-year-old gentleman who has a history of peripheral vascular disease, diabetes, hypertension, has multiple previous interventional procedures done, now presents with a critical limb ischemia And as you can see, he has multiple wounds on the different angiosomal areas. Obviously, you already know that this patient has multiple vessel occlusions. Here you can see that in the previous interventional procedures, he had a long stent placed into his femoral artery going down with the SFA, which precludes from the antegrade access. And in addition to having a severely diseased SFA, all his tibial vessels are occluded. So in this case, for convenience, here you can see that it has a very nice tibial reconstitution. So this is excellent for a retrograde access and utilizing the tibial vessels to do intervention. You can see here severely calcific vessels, but under ultrasound an access is obtained, and this is a retrograde injection. You can see the AT is totally occluded. I was able to get through to the AT easily, and this is a 1.25 micro crown retrograde CSI, and it was followed by very low pressure balloon dilatation, and we can see very few or minimal dissections comparing such a severe calcific vessel. Now, this patient has again occluded posterior tibial artery, which was flushly occluded at the popliteal. So access was obtained to the posterior tibial artery. And here you can see the setup. Originally went from the right groin up and over, took the diagnostic images, decided that I think the ideal would be to do retrograde therapy, and we did the anterior tibial and the posterior tibial accesses. Now here you can see that retrograde injection with flush occlusion of the posterior tibial artery, retrogradely wire, CTO wire. It's Asahi Halibut wire along with the 014 Trailblazer is going, and I was able to get through to this occlusion, followed by retrograde diamond-back atherectomy to the TP trunk and posterior tibial artery, and followed by kissing balloon angioplasty to prevent any plaque shift to both areas. And you can see eventually we have very good results. And this is a hemostasis. This is a second case, a 75-year-old gentleman who came with a rest pain and occluded popliteal and distal SFA. This is just the fluoroscopy, just to let you know how severe the calcification was. Antegrade, unable to get through because it was extremely calcific vessel, so retrograde access was obtained, and as you can see, I'm trying to get through retrogradely, and with the help of both anti and retrograde access, I was able to get through the retrograde access. Now this sheath wire was externalized from the antegrade sheath, and it was followed by, now this is the biggest crown 2.0 solid, and so antegradely went through to the diseased area, and it was followed by balloon angioplasty with very good results comparing very complicated, very severely calcific CTO. Here you can see that this is a final angiogram. So in conclusion, orbital atherectomy is safe and effective in treating patients with severely calcific vessels with the high success rate and low complication rate. Low profile devices could be used retrogradely via 4-pharyngeal retrograde access. Thank you very much for your attention.